Good afternoon, everybody. My name is Dr. Dejuan Kenchelow, and we are here to discuss the question that was posed on our social medias back on November 18th. Sorry, we are late a little bit, holiday season, and we are people too. So, from this one, we will be discussing upper GI bleed. The three counselors here that do these webinars are Aksa Chowdhury, MD, MBA, Dr. Russell Heckburn, and myself, Dr. Dejuan Kenchelow. Our emails are first initial, last name at mail.sjsm.org. Or if you just want to get in contact with all three of us at one time, you can email USMLE at mail.sjsm.org. So without further ado, we will look at a case related to upper GI bleed and kind of dive deeper into everything that is in the question that is relevant to our own learning, as well as some differentials and a little knowledge related to that as well. So the question that was asked was a 28-year-old woman without any significant medical history presents to the office after having one episode of painless production of a spoonful of sputum with specks of blood in it a day ago. She states that she had her period last week and had been taking large amounts of ibuprofen for 3 days. She also complains of having mild epigastric pain described as burning in quality and non-radiating. She denies having palpitations, nausea, vomiting, hematuria, or dizziness. Her physical exam reveals no apparent distress, moist skin, moist oral mucosa, regular heart rate and rhythm, lungs clear to auscultation, no abdominal tenderness, and a normal neurologic exam. What is the most likely cause of this patient's symptoms? Choice A, NSAID-induced gastritis. Choice B, perforated peptic ulcer. Choice C, Helicobacter pylori-induced peptic ulcer. Or choice D, essential dyspepsia. So we'll give a little bit of time for people to answer. So we'll go through some of the answer choices that we have here just to kind of define what they are, and then we'll give you another brief moment in case you want to change your answer at that time. So choice A, NSAID-induced gastritis, is going to be inflammation of the lining of the stomach due to the breakdown of the stomach's protective barrier due to inhibition of the cyclooxygenase 1 enzyme by the NSAIDs. Choice B is a perforated peptic ulcer. So that one would be an ulcer in your stomach or duodenum that goes through the full thickness of the mucosa and creates a hole between the inner part of your GI tract and your abdominal cavity. Super, super bad. Choice C, Helicobacter pylori-induced peptic ulcer, would be an ulcer in your stomach or duodenum caused by infection of H. pylori. This wouldn't be full thickness, so the normal ulcer. And choice D, essential dyspepsia, so discomfort or pain in the epigastric region of the abdomen without a known cause. So basically indigestion. So we'll go back and give you a chance to change your answer if you would like. Give it about 5 seconds. So the answer is choice A, NSAID-induced gastritis. So why are we thinking that? So to start, we'll just kind of delve a little bit into upper GI bleeds. So our patient had coughing up a lot of sputum with specks of blood in it. So that was the kind of clue for us to think about an upper GI bleed. So some of the differentials we want to think about would be gastritis, duodenitis, and esophagitis. So inflammation of the stomach, duodenum, or esophagus. Variceal bleed, especially as related to our alcoholic or non-alcoholic cirrhotic patients. Peptic ulcers, so an ulcer in either the stomach or duodenum due to stomach acid. can be caused by H. pylori, or it can be other causes. Gastric ulcer, inflammatory bowel disease, or tears at the gastroesophageal junction. So if you have somebody who has repetitive vomiting, like a bulimic patient, they can be someone at risk of tears of the GE junction that can lead to upper GI bleeding. So, in our patient who had her period last week and was taking a lot of ibuprofen for 3 days, ibuprofen being an NSAID, along with other drugs such as Motrin, Advil, aspirin, things like that. So, they work by reversibly inhibiting the cyclooxygenase enzyme. We'll just call it COX from here on out to make it a little bit easier. So, there's two enzymes, COX1 and COX2. COX1 is going to lead to the production of some prostaglandins that have a protective effect on our gastric mucosa. So if we block that COX1 enzyme, our gastric mucosa's protection is decreased, therefore at risk of injury due to the stomach acid we normally produce. So the symptoms of gastritis that we would expect to see in a patient can range from upper GI bleeding, so either vomiting or just kind of coughing up little specks of blood. Abdominal pain, especially in the epigastric area. So if you think kind of the upper middle part of your abdomen, right below your rib cage, that's kind of what you would expect. And a complication you would worry about with this NSAID-induced gastritis would be perforation. So in our patient, presenting with the coughing up specks of blood, the abdominal pain, and the heavy intake of ibuprofen the week below, that's classic presentation for NSAID-induced gastritis or ulcers. So gastritis, inflammation of the stomach, ulcer being a little bit further and having more damage to a specific place. Ours was more of a diffuse gastritis as opposed to the ulcer. If we look at the other options, choice B, the perforated peptic ulcer, could be a complication of NSAID use and the ulcer related, therefore, but we would expect a couple other more severe symptoms. So for one, we would expect to see hemodynamic instability. So this can be noted as unstable vital signs. So a decrease in their blood pressure and elevation in the heart rate. Sometimes fever can be present or not. We would expect some severe symptoms. So dizziness, lightheadedness, or passing out, syncope as we call it. And we would expect an abnormal physical exam, so something like abdominal rigidity, so a nice hard abdomen, or rebound tenderness. So if you were to press on a patient's abdomen and hold it for a couple seconds, they should initially have a pain that stops. And then when you remove your finger, take the pressure off, they would have the pain again as if you were just pressing on it. So because our patient had fairly normal vital signs, they denied dizziness, nausea, vomiting, and other symptoms, and they had a very normal physical exam, it's very unlikely that they've gotten to the point of perforation. Looking at choice D now, essential dyspepsia, aka non-ulcerative dyspepsia, aka functional dyspepsia, because why not have three names for the same exact disease, is dyspepsia without a known cause. So dyspepsia is pretty much the fancy medical term for indigestion or kind of a little bit of reflux. So for these patients, two criteria must be met in order to diagnose. One is a lack of risk factors. So our patient had the risk factor of heavy NSAID use recently. And the other criteria that must be met is an EGD, so an esophagogastroduodenoscopy, or a scope that goes in through our mouth and goes through our esophagus into our stomach and into our duodenum, and is going to look at the mucosa there. And having that showing no ulcers is the second criteria for essential dyspepsia. So our patient has known risk factors and did not have a recent EGD, so we can't say that it's essential dyspepsia. Looking at choice C, H. pylori induced peptic ulcers. So H. pylori can be synergistic with NSAIDs. If NSAIDs decrease the mucosal protection, and infection with H. pylori would lead to an increase in symptoms of ulcers and gastritis. However, we have no real reason to suspect H. pylori in this patient. Um, the only thing that's very similar is the epigastric pain described as burning or piercing, which our patient did have, but there's no mention of an uncomfortable feeling of emptiness, an uncomfortable feeling when her stomach is empty. Um, H. pylori as well is more likely going to affect the duodenum. So actually, the pain should be better with eating food, and the pain will come back about 30 minutes to a couple hours after eating the food. So classically, you can think of like somebody eating dinner and then going to bed within like an hour, and then waking up with, pain and indigestion kind of symptoms. That's one thing we kind of clue ourselves into H. pylori infection. But as far as our patient here, none of these things are really noticed or reported by them. So that kind of makes H. pylori a lot less likely. And that pretty much covers a little bit into upper GI bleed, especially as it related to this specific case. If you have any questions or need any assistance, feel free to email USMLE at mail.sjsm.org. That's USMLE at mail.sjsm.org, and we'd be more than happy to help you with any questions you have.